Welcome to this high yield explainer. आज के सेशन में हम क्रैक करेंगे maternal adaptations in pregnancy. देखो obstetrics में ना रट्टा मारने से काम नहीं चलेगा. You can't just memorize. If you just memorize isolated facts, you are gonna get totally confused in the exam hall. But if you understand the why behind every physiological change, the real funda of what the maternal body is actually doing, then suddenly every single clinical vignette becomes incredibly easy to solve. So let's dive right into this high-yield review.
Okay, so here is our game plan for today. We're breaking this down into 5 quick sections. We're going to use a master controller approach. Basically, we'll trace how pregnancy hormones, especially our boss, progesterone, drive all the downstream effects in literally every single organ system. Let's get started.
All right, Section 1. This is all about the reproductive system and those master hormones. Always remember, pregnancy is fundamentally a progesterone-dependent condition. Progesterone is the ultimate pregnancy maintainer.
Take a look at these original handwritten notes mapping out the endocrine changes. It's a lot of dense material, right? But don't worry, we're going to break all these concepts down step by step so the fundas are absolutely crystal clear for your MCQs.
Now, the prolactin paradox. This is such a fascinating concept. Students always ask me, Sir, prolactin is so high during pregnancy, तो milk production पहले क्यों नहीं होता? समझो इसको. Step 1. The pituitary and decidua are releasing tons of prolactin, huge amounts. But step 2 is the catch. Estrogen is heavily inhibiting prolactin's action on the breast tissue. Think of it like a strict brake. Then step 3 happens. The placenta is delivered. The literal second the placenta is out, maternal estrogen levels absolutely crash. Which brings us to step 4. The inhibitory brake is completely removed and boom, milk production kicks in. So the sudden drop in estrogen is the actual first stimulus for lactation. Mark this, it's a direct exam question.
Moving on to the cervix, you absolutely need to know these 2 buzzwords. First up is Chadwick or Jacquemuir sign. This is simply the bluish discoloration of the cervix and vagina, and it happens purely because of increased vascularity. Second is ectropion, or eversion. Because of the hormonal surge, the inner columnar epithelium of the endocervix actually grows outward, right over the squamous epithelium. Clinically, this patient presents with post-coital bleeding. Now listen carefully, the examiner will give you this exact symptom and ask for the next best step. The trick here? It is absolutely not premalignant. Do not click on biopsy in the options. No biopsy needed, just reassurance. Let's move into Section 2 and see how all this builds into broader systemic changes. We're going to look at hematology and exactly how the maternal body handles massive fluid shifts. Reviewing the source notes here regarding general changes, we see the basal metabolic rate increases by 10 to 20%, simply because pregnancy is such a highly anabolic state. But I really want to focus on the edema mentioned here, because this is exactly where students make those silly mistakes.
So, the absolutely crucial point here is distinguishing physiological edema from pathological edema. Physiological edema naturally subsides on rest. Pathological does not. Physiological edema is found strictly in dependent parts, so the feet when standing or the sacrum when lying down. If you see edema above the knee or on the face or a generalized anasarca, guys, that is pathological. Management for physiological, just rest and reassurance, nothing else. But pathological requires urgent medical management for pregnancy-induced hypertension or PIH. Confusing these two in a clinical vignette will cost you negative marks, yaar. So be very careful.
Next up, blood volumes. This brilliantly illustrates the concept of physiologic anemia. First, look at how the plasma volume shoots up by 40 to 50%. RBC volume also increases, but only by about 20 to 30%. So the liquid portion increases much more than the solid portion. The result of this? Decreased blood viscosity and decreased hematocrit. It's literally just hemodilution. Also, make sure to note the decreased platelet count. We call this benign gestational thrombocytopenia. It's completely normal, so don't panic when you see it. Now, think about this. If the blood is so diluted, how on earth does the baby get enough oxygen? Well, the maternal body is a genius. To compensate for this hemodilution, cardiac output increases. The maternal RBCs ramp up their 2,3 BPG, which causes a right shift of the oxygen dissociation curve. And a right shift means hemoglobin releases oxygen much more easily to the fetal tissues. Combine that with the decreased blood viscosity we just talked about, and boom, oxygen delivery is completely optimized. Awesome. Let's shift our focus to section 3, the renal system. This is where hormonal relaxation and anatomical pressure combine to create a perfect storm for clinical complications. So, we often see bilateral hydroureter in pregnancy, but why? First, our master relaxer, progesterone, relaxes the smooth muscles of the ureters. Peristalsis drops and the urine just sits there, urinary stasis. Secondly, it is always right greater than left. Why is that? Because the growing uterus naturally undergoes dextral rotation. It twists just a little bit to the right, pressing heavily against that right ureter. So you have anatomical compression combined with hormonal relaxation. Bringing up the original notes covering these renal changes and urine microscopy, you'll see physiological glycosuria happens because the renal threshold for glucose drops. But let's zoom in on the single most highly tested topic right here. Asymptomatic bacteriuria, or ASB. Guys, this is a 5-star topic. The diagnostic criteria is strictly greater than or equal to 10 to the power of 5 bacteria per ml in a midstream clean catch with 0 UTI symptoms. E. coli is the most common culprit here. Now, why do we even care if there are no symptoms? Because 25% of these cases will progress to acute pyelonephritis, and it's a massive risk factor for preterm labor. You absolutely have to treat it. The absolute drug of choice for your exam, nitrofurantoin. Mark it, learn it, don't forget it.
Moving swiftly over to section 4, we are now exploring the GI tract and the respiratory system. And as you'll see, our old friend progesterone is playing a huge role here once again.
Pregnant females invariably complain of acidity and constipation. Why is that? Well, progesterone causes smooth muscle relaxation everywhere. When the lower esophageal sphincter relaxes, you get GERD or acidity. When intestinal motility decreases, you get severe constipation. Even the gallbladder contractility decreases, which leads to stasis and a significantly higher risk of gallstones. Everything in the gut is just sluggish, all thanks to progesterone. Diving into the source notes for the respiratory system, you can see a lot of arrows and parameters here, but I want to highlight the core anatomical mnemonic and the critical lung volumes that examiners just absolutely love to target. First up, the 2-4-6 rule for anatomical changes. Honestly, guys, this is direct ratification. You just have to memorize it, but it is extremely scoring. The transverse diameter of the chest increases by 2 centimeters. The diaphragm is pushed up by 4 centimeters by the growing uterus, and the overall chest circumference increases by 6 centimeters. 2, 4, 6. Keep that little trick in your pocket for quick +4 marks on exam day. Now for the physiological changes. Minute ventilation increases, which washes out more CO2, leading to a state of compensated respiratory alkalosis. But here is the exact paradox they will test you on. The respiratory rate remains absolutely constant. The mother breathes deeper, not faster. Tidal volume increases, but RR is totally unchanged. Also note, because that diaphragm is pushed upwards, your total lung capacity, residual volume, and expiratory reserve volume all decrease. All right, we are in the final stretch, section 5. Let's decode the essential metabolic labs you need to know and a very, very important pituitary pathology. This next concept is literally a clinical lifesaver. When you look at an LFT in pregnancy, alkaline phosphatase, or ALP, will be high. This is completely normal. Why? Because the placenta naturally releases heat-stable ALP. However, SGOT and SGPT must remain perfectly normal. If those transaminases are elevated, it is a massive red flag. It is strictly pathological, pointing towards severe, dangerous conditions like HELLP syndrome. You never, ever brush off high SGOT or SGPT in a pregnant female. Next, let's talk about the iron and calcium paradoxes. For iron, almost all parameters decrease except for serum transferrin and total iron binding capacity, or TIBC, which actually increase. For calcium, the total maternal calcium decreases simply because plasma albumin drops, but the active, free, unionized serum calcium remains perfectly normal. And practically speaking for the wards, always remember the golden rule. You must maintain a minimum 2-hour gap between giving iron and calcium tablets, otherwise they'll just inhibit each other's absorption. Finally, let's talk about Sheehan syndrome. During pregnancy, the pituitary gland hypertrophies massively, increasing its size by 125%. Because of this, it becomes incredibly hungry for blood supply. Now imagine a mother has a massive postpartum hemorrhage, or PPH. Her blood pressure crashes. That enlarged pituitary suddenly gets starved of blood, leading to ischemic necrosis of the anterior pituitary gland.
This is Sheehan syndrome. The classic clinical presentation they'll give you, a mother who simply fails to lactate postpartum because her prolactin is just gone.
And that brings us to the end of this explainer. We've mapped out exactly how the maternal body brilliantly adapts its hormones, blood, and organs to support new life. But here is my final question to you. What happens the moment these perfect physiological boundaries fail, and we cross over into the dark territory of pathological obstetrics, like HELP syndrome or eclampsia? Keep studying, keep revising these core fundas, and we'll tackle those exact pathologies next time. Until then, stay focused, keep